Hello and welcome to a series of lectures on calcium. Calcium is a very important element playing innumerable physiological roles in our body. But despite this, it has a very narrow margin of safety. Its plasma levels need to be maintained between 9 to 11 milligrams per cent. And any deviation on either side gives adverse outcomes. It is also important for bone health. So in this series of lectures, we will see in 4 parts. First, the calcium homeostasis, that is how the normal levels are maintained. What are the drugs which affect it? And when do we need to use calcium as a medicine? In part 2, we will discuss the important consequence associated with low calcium, that is osteoporosis. What is the pathophysiology of osteoporosis? What are the physiological as well as lifestyle components which favor development of osteoporosis or which can protect us from development of osteoporosis? Then we'll go on to see the details of the 3 important hormones which promote bone health, namely vitamin D, parathormone, and estrogen. And lastly, we will study the newest additions to the armamentarium of drugs affecting calcium homeostasis and importantly bone. That is the anti-resorptive drugs, bisphosphonates, calcitonin, and denosumab. So this is how we will cover the contents in 4 parts. Let us start now with part 1, which deals with calcium homeostasis, role of the 3 hormones which are responsible for calcium homeostasis, namely vitamin D, parathormone, and calcitonin, which are the other hormones and drugs and even dietary ingredients which can influence calcium homeostasis, and as said earlier, when do we need to use calcium as a medicine to supplement the dietary calcium. Calcium, the active calcium being present as a cation with 2 positive charges, plays innumerable physiological roles. Calcium itself is the 5th most abundant element in our body after carbon, oxygen, hydrogen, and nitrogen. It constitutes about 2% of the body weight. It's an important constituent of bones and teeth. So almost 99% of the body calcium is present in the bones. It is an important neurotransmitter, or not exactly the neurotransmitter, but a transducer, component of a transducer mechanism involved in translating excitation, the excitatory stimulus brought along the nerve into muscle contraction, whether it be smooth muscle or skeletal muscle. Similarly, it is instrumental in materializing a stimulus into actual secretion of hormones as well as the neurotransmitters. It also works as an intracellular messenger in many cellular activities. It is the important component for bringing about the action potential, the depolarization component of action potential generated in the SA node and in the AV node in the heart. It is also important for activation of certain inactive coagulation factors in the process of hemostasis. It is important for certain enzyme activities and integrity of cell membrane in general. So it plays immense physiological roles, and even the calcium in bones is not a static component. It serves as a reservoir to replenish serum calcium if nothing is coming from the GI tract. So as I said, even if it is so important, it has a very narrow margin of safety in that its plasma levels need to be maintained between 9 to 11 milligrams per cent. These are the normal levels. And any deviation on either side manifests with adverse effects. Out of this calcium which is present in the blood, it exists in three forms. 50% of it is present in free ionic calcium. And it is this free ionic calcium which gets involved in all those physiological functions, which is responsible for all those physiological functions. And this ionic calcium can also diffuse out of the vascular compartment into the extracellular fluid compartment through the capillary pores, and it can also get filtered at the glomerulus in the renal tubules. 40% of calcium is bound with albumin and 10% is bound with citrate or phosphate. This 10% binding with citrate and phosphates is irreversible binding. It's not released from this binding for doing any work. Whereas the albumin binding with albumin and free ionic calcium, they're in equilibrium with each other. So 40% is albumin bound and 50% is free ionic calcium. But this is the ratio between bound and free at normal blood pH. And the ratio can change towards either bound or free depending on the blood pH. So if there is alkalosis, the balance tilts in favor of binding. And so free calcium will reduce. And if free calcium reduces, we get impacts because it's the free calcium which is actually doing all the job. And what can tilt this balance in favor of binding with albumin? Alkalosis. Alkalosis can happen as a consequence of hyperventilation. That is, excessive throwing out of carbon dioxide, which can also occur during hysteria. And then, if the serum or extracellular calcium falls below 40% of normal, then the person starts showing these tetanic contractions or convulsions, hypocalcemic tetany, more commonly manifesting in the small muscles like the muscles of the fingers. So you can see that this hypocalcemic tetanic convulsions, which can also involve esophageal spasm, can occur with just a shift in the percentage of free calcium available. There is no hypocalcemia as such. Serum calcium levels are still between 9 to 11 milligrams %, but only the free ionized calcium has reduced, and it gives manifestations like this hypocalcemic tetany, and more serious, it can also cause esophageal spasm. If you know what has caused this manifestation, you will be able to understand how we can easily reverse it without having to give calcium from outside, because we saw the serum calcium is normal. Only the balance has shifted towards binding because of alkalosis, which occurred because of hypoventilation, for example. That means excessive throwing out of carbon dioxide. So if we can correct this alkalosis, the 50% ionized calcium, that proportion will be restored and the tetanic contractions will be resolved. So just think for a moment. Having known the etiology, what is causing shift or reduction in free calcium, you should be able to think of a very simple way out. And the way out is, we ask the individual to breathe into a bag, and this exhaled air has got more carbon dioxide. So breathe in this exhaled air, and that will correct the alkalosis, and that will correct the tetanic contractions as well. So you can see that a little fluctuation in the free calcium also gives us adverse clinical manifestations. Not only that, just as hypocalcemia can cause hypocalcemic tetany or even esophageal spasm, chronic hypocalcemia can also result in osteoporosis. We discussed that if there is no calcium coming from gastrointestinal tract, either as a dietary source or as supplements, then the other important source to maintain this serum calcium level is bones. And so osteoporosis would be the effect of long-term hypocalcemia. Similarly, a little higher levels, just more than 11.6 milligrams percent, by any cause, due to any cause, can give rise to fatigue, mental depression, mental confusion, anorexia, nausea, vomiting, and even cardiac arrhythmias. So that is a consequence with just 0.6 milligrams percent more than the normal range. If it goes beyond 12.8 milligrams percent, then we get ectopic calcification, calcium deposition where it should not be, like in the blood vessels, in the muscles, in the heart. And if blood vessels get calcified, they lose their elasticity, their compliance, and that's going to compromise the blood supply to the organs they supply. And so if it happens in the coronaries, it can increase the risk of ischemic heart diseases, and it has shown to increase even the risk of myocardial infarction. Levels more than 14.8% can give real serious outcomes, that is coma and cardiac arrest can even occur. So you can see that though calcium plays such an important role in so many physiological processes, it has a narrow margin of safety. And the levels need to be maintained between 9 to 11 milligrams percent. Both hypocalcemia and hypercalcemia are associated with adverse manifestations. And therefore, in the body, there are 3 hormones employed to ensure the normal levels of calcium. And the 3 hormones are parathormone and vitamin D. We call it vitamin, but now we know it is manufactured in the body. So it is a hormone. So parathormone and vitamin D make sure that it doesn't go below 9 milligrams percent. And calcitonin tones it down. It doesn't let it rise above 11 milligrams percent. How do these hormones ensure that the levels do not deviate on either side? They manipulate the source of calcium into the bloodstream. And what are the 3 ways or 3 sources from which calcium can enter the bloodstream? One is the dietary calcium getting absorbed from GI tract with the dietary or the supplemental calcium tablets that we may consume. But gastrointestinal absorption can bring calcium into the bloodstream. As we discussed, this free ionic calcium does get filtered at the glomerulus, but it is getting reabsorbed as well. And this renal tubular reabsorption is another source for calcium coming back into the bloodstream. And the third one is dissolving the bones, bone resorption. So these are the 3 ways by which parathormone and vitamin D directly or indirectly facilitate these 3 processes which bring calcium into the bloodstream and thereby make sure the levels don't go below 9 milligrams percent. Calcitonin, on the other hand, reduces the entry into the bloodstream. Fortunately, it reduces the entry only from renal tubular reabsorption and bone resorption. It does not interfere with the gastrointestinal absorption of calcium. So calcitonin ensures that it doesn't go high by blocking the entry by renal tubular reabsorption and bone resorption. This is how the physiological homeostasis or maintenance of normalcy of calcium is happening in our body. So this diagram again shows you that these are 3 ways or 3 sources from which calcium can enter the bloodstream, and calcitonin is inhibiting bone resorption and renal tubular reabsorption to make sure it doesn't rise above 11 milligrams percent. How do vitamin D and parathormone work? And some other drugs which may also have effect on this homeostasis. As I said, vitamin D is actually being manufactured in our body. So we now refer to it as a hormone. And the starting material, the raw material, is cholesterol. So cholesterol in the skin under the influence of UV rays from sunlight, lead to formation of the conventional vitamin D, the vitamin D3, that is cholecalciferol. But this is the inactive form of vitamin D. It is activated in the body further in 2 steps by addition of 2 hydroxyl groups, OH groups. The first one is addition in the liver, where the hydroxyl group is added at position 25 in the molecule of D3. And then in the kidneys, one more hydroxyl group is added at position 1. This is called 1-alpha hydroxylation. And this ultimately will give rise to a molecule which has 3 hydroxyl group. One OH group is already present in cholecalciferol. One is added in the liver and another one is added in the kidneys. So final molecule has got 3 OL groups, hydroxyl groups, and therefore it is called calcitriol. 3 OH groups. And this is the final active form of vitamin D, which is involved in this calcium homeostasis. So this calcitriol is what will promote gastrointestinal absorption of calcium, and along with it also phosphate. That is important because both calcium and phosphate, calcium phosphate is required for bone mineralization. So calcitriol will facilitate gastrointestinal absorption of calcium as well as phosphate. It will also facilitate, it can facilitate bone resorption as well. And it will also facilitate renal tubular reabsorption. Even though we say vitamin D, it is calcitriol which is doing all this. Okay, the active form of vitamin D. What about parathormone? Parathormone itself has no effect on gastrointestinal absorption of calcium or phosphate, but it ensures the renal hydroxylation of vitamin D, that is 1-alpha hydroxylation, which will form calcitriol. And this step of addition of hydroxyl group at position 1 is called the rate limiting step in this entire process of synthesis of active vitamin D, that is calcitriol. What do you mean by rate limiting step? If a process involves multiple steps, the slowest step will decide the overall rate of the process. Just as if we consider a chain, the weakest link decides the strength of the chain. The rest of the chain may be very strong, but the weakest link decides the strength of the chain. Similarly, the slowest step will decide the overall rate of the process, and this renal hydroxylation is the key rate limiting step in activation of vitamin D to form finally calcitriol, and parathormone ensures this 1-alpha hydroxylation. And indirectly, by activating vitamin D, it is promoting gastrointestinal absorption of both calcium and phosphate. It can itself directly promote bone resorption, and it also promotes renal tubular reabsorption of calcium. But there's a difference here. Vitamin D, calcitriol, promotes renal tubular reabsorption of both calcium and phosphate, whereas parathormone promotes reabsorption of only calcium at the cost of phosphate. So phosphate is lost under the influence of parathormone, only calcium is retained. And this hypophosphatemia can also affect bone mineralization adversely because both calcium and phosphate are required for mineralization. There are some other hormones who have as their primary role some other function, but they need calcium for effective execution of their primary function. And these hormones are estrogen and prolactin. Okay? Yeah. One point. By making calcium and phosphate available, these two hormones, parathormone and calcitriol, also promote bone deposition. Coming to the other two hormones, that is estrogen and prolactin, because they do need calcium for executing their primary roles. That is, prolactin is going to stimulate milk production, and milk is rich in calcium. It needs calcium. So prolactin also ensures that active form of vitamin D is formed, calcitriol is formed, so that gastrointestinal absorption of calcium, dietary calcium or supplemented calcium will be ensured. Estrogen also facilitates this rate limiting step, and in addition, it also promotes reabsorption of both calcium and phosphate from the renal tubules. The difference between estrogen and vitamin D and parathormone is, on the bone action is, estrogen prevents resorption of bone and positively promotes deposition of bone. Not only the bone mineralization, but also promoting the laying down of the bone matrix, the osteoid, the proteins, which are required for building up of bones. That is also facilitated by estrogen. Thus, estrogen is important for bone deposition, not only mineralization, also the matrix. And if that is deficient, the person becomes prone for osteoporosis. So I hope you realized why postmenopausal women are at a greater risk of development of osteoporosis, because estrogen levels will be not available as otherwise. Amongst diuretics, we've seen that thiazides promote renal tubular reabsorption of calcium, while furosemide inhibits this renal tubular reabsorption. One more hormone, glucocorticoids, the corticosteroid, hydrocortisone, can counter the effect of vitamin D and reduce gastrointestinal absorption of calcium and phosphate. Similarly, phenytoin opposes the action of vitamin D. Phenytoin, an anti-epileptic drug, opposes the action of vitamin D and reduces the absorption of calcium and phosphate from the gastrointestinal tract. Drugs like tetracyclines do not oppose the effect of vitamin D, but they will bind with the intestinal calcium to form insoluble complexes. And an insoluble complex will not get absorbed. Some dietary contents like phytates and phosphates, say in uncooked spinach, that can also complex calcium, converted into insoluble complex, which will not be absorbed. So certain dietary components, certain drugs can form insoluble complexes and thereby prevent absorption, and drugs like glucocorticoids and phenytoin, anti-epileptic drug phenytoin, they oppose the effect of vitamin D and thereby block the gastrointestinal absorption of calcium. Why do we need to use calcium as a supplement? In spite of this very miraculous mechanism, which is entrusted the responsibility of maintaining the balance, the adequate plasma levels. If there is no dietary intake, yes, calcium levels will go down. And along with it, there would be osteoporosis as well, because body tries to release calcium from the bones. This very mechanism, which is maintaining the homeostasis. So if there is severely low calcium, there can be tetanic contractions. We saw even just tilting the balance, just not reduced availability of ionized calcium, though the overall calcium levels are same, can cause tetanic contractions. But if it is because of hypocalcemia, we do need to give calcium from outside, and depending on the severity of the situation, calcium can be given intravenously or orally. So intravenous administration of calcium is done as calcium gluconate, 10%, and we can give 50 to 100 milligrams of calcium gluconate as slow intravenous infusion every 6 hours to restore the calcium levels, or orally it can be given as 1 to 1.5 grams per day, along with vitamin D, of course, to ensure the absorption of the orally administered calcium. In patients with increased requirement, like growing children, adolescents with growth spurt, or pregnant or lactating mothers, where the requirement is more, again, And the diet, if it is inadequate, they would need dietary supplements of calcium. But remember always, dietary calcium is the best source of calcium. And if we do give calcium as a medicine, the recommended single dose is 500 milligrams of elemental calcium. And if the requirement is 1.5 grams, then 500 milligrams can be given 3 times a day. But at a time, the dose recommended is not more than 500 milligrams because the percentage absorption of the dose, the bioavailability, reduces if more is given at a time. So the recommended dose of oral calcium is 500 milligrams of elemental calcium. To treat or prevent osteoporosis, again, we may require elemental calcium 500 milligrams twice a day or thrice a day with vitamin D to ensure the absorption of this orally administered calcium. Intravenous calcium gluconate, when it is administered intravenously, it can cause severe cutaneous vasodilatation. And this vasodilatation all over the body gives a sense of warmth and a perception that some very active drug has been given. And therefore, it works as a very powerful placebo. It should not be misused, but yes, if we do not have any medication for the for a patient, maybe it's a psychological situation where the patient is just not convinced that there's nothing wrong, then it could be used as a placebo, therapeutic placebo. Or if you do not have anything and you don't have the heart to tell the patient that, no, you just await your fate, we don't have anything to give you. That's where placebos do have place in therapeutics. And calcium gluconate serves as a very powerful placebo because the patient perceives that some very powerful drug has been given to him because there's a sense of warmth all over the body because of cutaneous vasodilatation. And the same action is found to be useful in treatment of dermatosis, skin conditions, where this cutaneous vasodilatation may be removing the toxins, improving the tissue perfusion, and thereby helps relief from dermatosis. So these are the clinical uses of calcium. As a medicine, it is available as tablets with vitamin D combinations. But we need to remember that dietary calcium is always the best source of calcium. Excessive calcium intake, excessive calcium supplementation, as we saw, can also lead to ectopic calcification and has increased cardiac problems. And so dietary calcium is the best calcium source. So this is what we have covered so far. Please try to recollect what are the 3 forms of serum calcium, what is the effect of plasma pH on distribution of calcium in these 3 forms, and what happens in case of alkalosis, and how can we correct it. Third important thing, we saw that prolonged hypocalcemia can lead to osteoporosis because body tries to replenish the calcium from bones. Okay. So what is the effect of prolonged hypocalcemia? Which hormones help us to avoid hypocalcemia? What are the effects of hypercalcemia? And which hormone is responsible to avoid hypercalcemia? And of course, the clinical indications of calcium. That is what we covered in this first part. So revise it before you start seeing calcium part 2. So this was first of the 4 parts of a series of lectures on calcium. Thank you for visiting. Please do come back for the next part.